This is a phenomenal group of people. I will let Jessica, you've got the bios, I'll let Jessica introduce this. But this whole notion of what's federal, what's states, it took me a while. I still blow it occasionally about thinking that federalism really means the federal government. It means the opposite. But having said that, let me turn it over to Jessica and we'll have fun.
Can I just use this?
Oh, you got your own. Okay, great.
Hi, everyone. Welcome to today's course. I'm going to start off by giving maybe a 20-minute or so overview of the themes for this evening, just in case any of you out there might not have done the reading for tonight's course. And then I will introduce the panelists, and we will spend most of the time with a panel discussion followed by a Q&A at the end. So when there's a health policy issue that you want to address, there's two important questions to ask from the get-go. First is which level of government, federal or state, should address the issue? And then second, what's the best approach or what's the best regulatory tool? And so I'm going to introduce those two concepts, and then our panel discussion will flesh those out in the context of looking at Medicaid, Medicare, and healthcare reform. So as most of us know, in the United States, we have a system of government known as federalism. We have this big centralized authority known as the federal government, but we also have these 50 autonomous constituent jurisdictions, so the 50 states. And under the US Constitution, healthcare is an area where both the federal government and the states have the authority to regulate. So our healthcare regulatory system is this mishmash of federal regulation and state regulation. So when you have a healthcare problem, you might say, okay, is this an issue that we should address exclusively at the level of the federal government? Or is this an issue that should be left to the states? Or is this an issue that we should have some combination of the two addressing? And each level of government has its advantages and disadvantages. And so I want to walk through some of the factors that you would take into consideration in deciding whether you might want the federal government to intervene or the state or the combination of both. So loosely speaking, these factors fall into three broad categories. The first is known as political philosophy. And this is getting at the idea that we have some fundamental democratic values, such as representative government or equality. And we might ask whether the states or the federal government better promotes those values. And then the second category is political and economic competition among the states. The idea that if states compete with one another, it may lead to either better policy outcomes or worse policy outcomes. And then the final category of considerations is just pragmatic considerations that get at the idea of which level of government might just do a better job here. So I'll start with the philosophical rationales that favor the states. So one democratic value we have is wanting popular control over the public agenda. And so some factors that favor states here are that states are geographically smaller, and so we're more likely to see greater uniformity among voters in terms of their policy preferences. So it makes it more likely that a state action will reflect a large percentage of citizens' preferences, whereas at the federal level, you might see 51% of voters think something's great, but 49% aren't so happy with the federal action. Also, because states are smaller, it's easier for elected officials to learn voters' views and preferences, and therefore we might think it's more likely that state laws will reflect those preferences. Another consideration is known as value pluralism. This is the idea that we might see greater diversity in policies across the states as opposed to this single uniform approach that we would see at the federal level. And that states therefore may be more likely to, in the policies they adopt, be representative of citizens' views. And the reason for that is because we can choose which state we live in. We can choose to live in a state that maybe if we're conservative has more conservative policies, if we're liberal has more liberal policies. Whereas at the national level, if you don't like the policies of the federal government, it might be kind of hard to move to another country. Okay? And then a final consideration that favors states are this idea of smaller government is better. So states are inherently less powerful because, as I'll talk about in a little more detail, they're not able to raise as much revenue. So state policies tend to be less ambitious. They tend to be smaller in scale. So if you're a libertarian, you would favor state action because you might anticipate that states' approach to these issues will be smaller, whereas the federal approach will be bigger or more aggressive, which is a bigger threat maybe to individual liberty. On the other hand, there are philosophical rationales that favor federal intervention. So we increasingly have a strong national identity where we think of ourselves as American citizens. And this reflects the fact that the country is more integrated, the national economy is stronger, there's been big improvements in transportation and communication. So people have, therefore, often a bigger national identity than a state identity. I'm not sure that's true in Texas. I think we might be the exception to that generalization. But I grew up in Connecticut, and you don't say, yeah, I'm from Connecticut the way you do. You say, yeah, I'm from Texas. So if you have a sense that your national identity is stronger, you might think that everyone, all American citizens, should have the same rights and the same burdens. So that would favor national action. Another factor is social justice. And this is getting at the idea that certain rights and responsibilities should not vary across state lines. So for example, if you thought everyone should have a right to health care, you would favor federal action to ensure that. Similarly, there's a belief that the federal government may do a better job protecting more vulnerable citizens. In part, this is because historically, states have not always been as protective of minority groups as perhaps the federal government. You know, we can debate whether that's still true today, but today, one thing that does seem to be true is that fiscal challenges at the state may hamper their ability to protect more vulnerable populations. So moving to the next big category, political and economic competition among the states. Here the idea is that states compete with one another for citizens and businesses, and that will impact whether or not the state will intervene to address a particular policy issue, and then second, if they do intervene, how effectively they will do so. So the sort of pro-state story you hear is that states will compete with one another for residents and businesses, will work really hard to have, policies that have a positive impact. Whereas at the federal level, there's not really any competition there because citizens and businesses, well, businesses to some extent, are not likely to leave the United States for another country. On the other hand, competition among the states might not always lead to desirable policies. So as states compete with one another to attract wealthier citizens or businesses, they may want to keep their tax burden low, which means there may be less tax revenue to address certain problems that would require a significant expenditure of public funding. Relatedly, states might be reluctant to fund welfare programs because they may fear that if they generously fund welfare programs, their state will be inundated by low-income individuals coming into the state to take advantage of those programs. And then finally, states might be hesitant to impose stringent regulatory burdens on businesses because the businesses then may leave the state and go elsewhere. And then let me finally talk about that category about more pragmatic considerations. Again, this is getting at the idea whether there's attributes of the state and federal government that may impact how effectively they will address a particular policy issue. So factors that favor states is, one factor is this concept called laboratories of democracy. And this is getting at the idea that we don't always know what the best approach may be to address a particular policy issue. And so states can try different approaches, so we can have this big giant experiment across states to see what works well and what doesn't work so well. Whereas at the federal government, where you're more likely to have a uniform approach, you can't then experiment as easily with different policy approaches to see what works best. Second, there may be some issues that are inherently local. So healthcare, in many ways, is inherently local. If you're sick, you go to the local hospital, the local doctor. So here in Houston, if you're sick, you're not likely to go to a hospital in Los Angeles or New York. And then relatedly, some issues or some problems may vary across regions. So the opioid crisis has hit some parts of the country much harder than others. So as a result, this one-size-fits-all solution might not work, right? One-size solution being what the federal government may do, and we might instead prefer states having more local solutions that can be tailored to their unique local situation. And then finally, for some issues, it may be more politically feasible to have states intervene. States, might have less diversity of viewpoints within the state, and so therefore it might be easier to build consensus or support for some sort of political action, whereas at the national level we may just see greater diversity, so it may be harder to build a consensus. On the other hand, there are some pragmatic considerations that favor the federal government, whereas some issues may be inherently local, other issues may be inherently national. In other words, they might implicate a national interest because the benefits or the problems accrue at the national level. So defense is an example of that. There also may be problems that easily impact not just one state, but go across state borders. So a contagious disease, right, is unlikely to stay in a state. It can easily go across state lines. Drugs that are manufactured and sold nationally, we might think of that as something inherently national because it could be very costly for the manufacturers of prescription drugs to have to comply with 50 different state laws. Another consideration is fiscal capacity. So states are often constrained fiscally because they often have balanced budget amendments that foreclose deficit spending. Also, many state constitutions will have a fixed tax rate or no income tax, which can hamper states' ability to raise tax revenue. The federal government, in contrast, I think as we hear about a lot, can assume deficits, can also tax progressively, and therefore it's easier at the federal level to raise tax revenue. Another consideration is redistribution of resources from wealthier individuals and businesses to poorer individuals. At the federal level, if we have intervention there, we can address wealth disparity across states by having the wealthier states kind of taking revenue from them and then giving it to poorer states. So if you want more equitable spending across state lines, you might favor federal action. And then a final consideration is just institutional capacity. Some people think that the federal government, and specifically the federal bureaucracy, is generally more effective and more efficient than state bureaucracies. They point to the economies of scale we gain when we have just one government entity, the federal government, addressing an issue, as opposed to 50 different state government agencies doing so and duplicating each other's efforts. And a few people, or more than a few people, but this is controversial. Some people think that just federal bureaucrats are more competent. Maybe unclear whether overall that's true, but studies have found that there is wide variation across state agencies in terms of their competency. Some states have large, highly professional bureaucracies, other states maybe not so much. And then federal employees do tend to be paid more than state employees, so the federal government may be able to attract more talented or experienced individuals. So once you've kind of gone through all those factors and decided whether you want to have intervention at the federal level or the state level or a combination of the two, then you got to think about how should we approach this issue. So let's say a state says, we want to have some sort of intervention here to address the mental health needs of a particular population. The state could decide to directly provide the mental health care to those individuals by employing mental health providers. The state could decide they will contract with private mental health providers to provide those services. Maybe they can decide we'll just give vouchers to patients and they go find their mental health providers. Or maybe the state will just give a grant to mental health providers and say, take care of this population. Okay, so different regulatory approaches. And one of the readings for today, the Solomon, gives you a framework for thinking about which regulatory tool might work best. So the reading listed some of the tools. I'm not going to go through all of them, but I'll just highlight a few on the list. One is the direct provision of services, so that's where the government itself is the provider. So the VA system, Indian Health Services are two examples in the healthcare world of that. Contracting is where the government will contract with private actors to provide the service. So in Medicaid and Medicare, we often contract with private insurers to actually provide insurance to Medicare and Medicaid enrollees. Then there's command and control regulation, sometimes called social regulation. And these are just the rules or regulations that either restrict people's behavior or require certain behavior. So the HIPAA privacy rule would be an example of that. Now, where command and control regulations uses a stick to get people to behave a certain way, economic incentives is more of a carrot, right? Economic incentives would either encourage or discourage certain behavior through financial incentives such as tax subsidies. Okay. Then there's information disclosures, where the government provides information to consumers to promote more informed decision making. Another regulatory tool, which we don't see too often, is economic regulation. And this is where the government sets prices. So the state of Maryland, for example, sets prices for hospitals in the state. So how do you go about evaluating which regulatory tool might work best? So Salomon gives 5 criteria for doing so. So the first criteria is effectiveness. So you look at a particular regulatory tool and you ask, how likely is it that this tool will achieve its intended purpose, right? So if your goal is to improve access to mental health care, will this regulatory tool do that? Second factor is efficiency, which is weighing overall cost and benefits. So on the benefit side, obviously, it overlaps a little bit with effectiveness. It's how likely you are to be achieving your intended policy goal. But you also might take into account any other positive byproduct. So if you increase access to mental health care, maybe there's less crime or it increases worker productivity. So you would include that in the benefit side as well. And then the cost side are the cost to the governments as well as the cost to non-government entities and individuals. So you could have a tool that may be highly effective. It's very likely to achieve your policy goal, but it may be very costly and as a result might not be the most appropriate tool. Third factor is manageability. And this gets at the ease or difficulty of operating the government program. So the more complex a regulatory tool, the harder it is to manage the program. So for example, if you have a regulatory program which has lots of separate actors, maybe some government actors, maybe there's some private sector actors that you need to have the government actors overseeing, that can be hard to manage, right? So the more the moving parts there are, the more likely it is that something might not work as well as you would hope, and then maybe the less likely it is you would achieve your goals. Equity is used by Salomon in 2 ways. So the first way equity is used is getting at fairness considerations. To what extent are the benefits or cost of this particular regulatory approach evenly distributed? So with the Medicare program, all individuals over age 65 are eligible. So at least among the elderly population, it's fair or equitable. Equity also gets at redistribution considerations. If your goal is to channel the benefits of the regulatory intervention to certain populations, maybe a vulnerable population, then you would ask, well, how successful will this tool be at actually targeting intended beneficiaries? How likely is it that maybe some beneficiaries might actually fall through the cracks, or how likely is it that the benefits might flow to unintended individuals rather than your beneficiaries? And then the final factor is political legitimacy and feasibility. So the feasibility piece is getting at what extent will there be political support or political opposition for this particular regulatory approach. So you might determine that a regulatory approach is highly effective, but going to be very highly controversial in the political arena, so it might not be the right approach. Excuse me. And then political legitimacy is getting at the idea that some tools are better at facilitating political accountability. So in other words, we're looking at how likely is it that the public will perceive a connection between the government action and the end result, whether it's positive, negative. And if the public sees that connection, they can hold policymakers accountable. So if a program works well, they can say, great, we're going to vote for you again. And if it doesn't work well, they can change who they're going to vote for. So that's my overview of the themes for tonight. Now we're going to turn to the panel discussion. So let me first introduce the panelists. You have their full bio, so I'm not going to go into too much detail about who they are. Just a little introduction. So first we have here Seth Chandler. He's a professor at the University of Houston Law School. Seth is a nationally recognized expert on healthcare finance. He is the author of a well-read blog that's published by Forbes. And then we have Cedric Dark, who's an assistant professor at Taub's Department of Emergency Medicine at Baylor College of Medicine. He's also the founder and executive editor of Policy Prescriptions, which is a publication that advocates evidence-based policymaking. Then we have Rosie Valadez McStay. She's the assistant vice president of government relations at Texas Children's Hospital, where she advocates for children's health as well as addressing community health gaps. And finally, we have Ling Zhu, who is an associate professor of political science at the University of Houston. And her research interests include looking at health disparities and access to healthcare and kind of the political aspect of policy making. Okay. So I'm going to sit down for a minute for the rest of the time and turn now mostly, I hope the panelists will talk so I can drink some water. So my first question for the panelists is looking at Medicare and Medicaid. So Congress has created Medicare and Medicaid at the same time, but took very different approaches to the two programs. So Medicare is a federal program operated only exclusively at the federal level, whereas Medicaid is a partnership between the federal government and the states, with each state designing and operating the Medicaid program within federal parameters and the federal government partially funding those programs. So I want to ask the panelists, do you think it made sense to set up Medicare and Medicaid this way? Or do you think maybe Medicaid should have been or should be now a federal-only program? Or conversely, should Medicare be like Medicaid, where it's this hybrid federal-state program?
Should we draw straws?
Well, since you opened your mouth first,
Yeah.
you get to go first.
So, hi everyone. I think a lot of these issues are kind of clouded or at least influenced by sort of your personal background, your personal beliefs, because a lot of this, I think, deals with kind of the things you talked about, is like what you actually believe is the proper role of federal government and the proper role of state government and the proper role of individuals dealing with this. From looking at the way Medicare and Medicaid came to be in 1965, I think it was an appropriate way to do it because, you know, there have been pushes to do a nationalized type of health insurance system going back probably to about the 30s or so, and didn't really happen under FDR. Eventually they were able to get that over the hump, but I think that there was a viewpoint that there should be some kind of program for the poor as well as just the elderly. And I believe the convention was the way that certain services were delivered at that time was largely through state processes, and I think it just made it easier to tag Medicaid into the Medicare program, or tag it into a package and get people on board by keeping a lot of the delivery of that at the state level, as opposed to making it another federal program.
So I would say there is some logic to Medicaid being a half federal, half state, 2/3 federal, 1/3 state program. And the problem, I thought, was very well set out by Professor Mantel, and that is, imagine that you are a liberal, redistributive state. You're citizens, you're Vermont, you're California, and you believe that the poor should really be helped out and not be deprived of medical care and whatever else. You still have a very hard time accomplishing your goals, because the minute that you raise taxes, which as a state you will be bound to do, you can't just print money anymore, you will find that you become a magnet for the people who need help. And under a dreadful Supreme Court decision called Shapiro versus Thompson from the Warren Court era, you cannot constitutionally say, newcomers to the state, you are not eligible for this program unless you've been here for some period of time. You must treat newcomers to the state the same as you treat your existing citizens. And therefore you become, as I say, a magnet. So the solution to that is to not have the state raise taxes and have special benefits, but to have the taxing authority basically go to the federal government, which can then distribute money to the states. Moreover, the other problem is you might be a liberal state, a state that favors redistribution, but you also happen to be poor. And therefore, you don't really have the tax base that would let you be as redistributive as you might like. And so you can see, maybe with the benefit of hindsight, at least reconstruct some logic to the Medicaid program in that it overcomes to some extent the problem of foot voting and the problem of limited tax capacity by A, placing the taxation powers with the federal government, and then B, having differential reimbursement rates so that Connecticut gets a lower rate of reimbursement for their traditional Medicaid patients than does Mississippi. Right? Medicare is a little different, and we have to I think, distinguish between Medicare Part A and the rest of Medicare. Medicare Part A is not, at least as originally formulated, all that redistributive. That is, it's a forced savings program. Now, it is true it's become more redistributive as we've increased the taxes for it, but it's not intended really to redistribute money from the rich to the poor. Rather, it's intended to make sure that you have adequate care when you're older and you might not have saved adequately for that and would otherwise be placing the burden on charities or receiving substandard care. And so there, it's a little hard to see how Professor Mantel's ideas of foot voting fit in. That's not to fault her at all, it's just to say that it's not quite so clear to me why that needs to be done on a federal level. What I would say, though, is as a practical matter, imagine state Medicare. You live in New York for most of your adult life, you're working away and contributing to this New York Medicare retirement fund, and now you move to Florida for your retirement, which has a very different system in place. There are an awful lot of coordination issues that would have to be resolved in that setting. And I wonder if the fact that this would just be taking place over a long period of time might make a state-based Medicare system not particularly practical.
So I would want to just remind everybody, I'm not sure how familiar everyone is with regard to the Medicaid program, but in its inception, it was for pregnant women and children. And we, as states across this country, have decided to add on populations over time. So suddenly the Medicare program, because of its inability to sustain itself long term, started to say, you know what, states, if you would like, you can include your aged and disabled population under the Medicaid program. So that has ballooned a lot of the states' budgets with regard to this program. So with regard to how it is, and the partnership is there, but the partnership now suddenly, at least what I see in the arena of health policy, especially at the state level and even at the federal level when we saw the president's budget, is that suddenly the checkbook is going to get closed. And when a checkbook gets closed, or it's like, hey, this is where it is, and we're going to cap it out, and you can have all the flexibility you want, states, to do what you think is right for your population, I think to Professor Chandler's point is that you can vote, and also to Jessica's point is, you can move with your feet, but if you're poor, it's a lot harder to do that. So when you can't move with your feet, and you are in a state that suddenly has decided, you know what, we're going to try novel approaches to the Medicaid program. We're going to do this in partnership. The state has a petition to have that flexibility. The whole idea of the pragmatism, like we can do it better. If you just take off the handcuffs and let us do what we need to do, we will make sure that we cover all our populations the way we think it needs to be done. The problem there is that suddenly you realize that to take off those handcuffs and you have a cap on the amount of expenditures that you can spend it on. You don't want to raise taxes because you want to bring those businesses in. You don't want to make sure that you're going to have the ability to take care of all the people in it. So you're going to maybe have some work requirements, maybe some education about it, because you want to get these people up and you give them a hand up, not a handout. Suddenly that program and that partnership begins to get very strained. On the Medicare side, and unfortunately this is not my forte, but I would say that I have to agree that the federalism part of this, it would be very difficult. And again, they're aged and disabled. It was a program, and for them, low income as well. It's not like seniors can suddenly say, you know what, I should go get a job at 75. I've only been working my entire life. Let me go ahead and get some more dollars under my belt. The problem here, though, is that we have not thought about how we're going to save. And so I'm looking at the sort of the trends of, wow, I'm starting to be in that population. I'm the Generation X, so I'm going to be in the next 10 to 15 years going into this program, and I'm realizing if I hadn't saved early on, this would be a big challenge for me. Especially, I just hobbled in here on a boot. If as a senior, I don't have that ability to access that type of care. If I haven't the ability or the health to be able to do the rehab, take the medicines, et cetera, I could price myself out of a home. I could price myself out of any type of standard of living that I was grown accustomed to in my youth and in my middle age. So I think that at the federal level, it is a lot easier to have that sort of overview of like, you know what, we have to have at least all, the playing field is equal across. It isn't going to be an experiment of choice and you can move around. So I would have to agree that would be a challenge to make this a state-to-state kind of program.
Let me also add on, since we've also mentioned about the feasibility of policy changes, I would like to add on to, instead of thinking about why we have a two-tier system based on the financial logics and the physical considerations, if we think about ultimately any major policy changes moving forward are going to be decided by voters. An interesting observation or comparison between the two programs is that American voters to date, right, the debate about whether a national government should be responsible for taking care of the elderly in terms of a healthcare need has already been finished, right, back to the 60s, yet we're still having ongoing debates, and citizens and voters from the 50 states, to my observation, do not have reached to any consensus about whether it should be a government responsibility, right, and let alone the state or national level responsibility in taking care of the healthcare needs, especially from the working poor adult population. So because of, I think fundamentally, public opinion also plays a very important role in the policy-making process in this country. That creates the gridlocks, that creates the slow-moving process of changing the configuration of the current Medicaid program. If you think about a comparison, for example, in terms of who are qualified for receiving Medicaid benefits here in Texas versus those who live in California, you'll maybe not a big surprise, but you'll find very sharp comparison that here, again, state program here only covers pregnant women, young children, not the large proportion of working adult population. But the
exceptionally poor to
yes,
qualify as an
or
adult.
disabled,
or
being
disabled.
qualified. Yeah, but in other states, the public opinion foundation is different in terms of who deserves the government protection and responsibility. So we still have the ongoing debates.
We do. One thing I do want to just add to this discussion of, should Medicaid, is it a good thing that it's at the state level or not? I think you've heard some of the concerns about having states take on a bigger role with Medicaid, but let me just play devil's advocate, because that's what I'm supposed to do as the moderator here. That there is it is very challenging to care for many of the populations on Medicaid. And one thing that we are seeing in healthcare right now is a lot of experimentation, I think, and innovation across state Medicaid programs of how to care for these populations. So I know some of the other panels that you've probably all have heard or will hear in the next few weeks will talk about the social determinants of health. I mean, I really think Medicaid is really, in many ways, at the front of trying to figure out how to address social determinants of health. But it's a big experiment because no one's quite sure of the best way to do so. Now, I do want to pick up on the themes about the president's budget that came out yesterday. So this is very timely. I know Rosie started to talk about that.
I mean, the president's budget's not going to go anywhere. I just want to
No,
lay
it
that out
probably
there.
will
I mean,
not.
It's going to be a big doorstop for people, but.
But one thing that was in that budget is something that we've seen over the past few years coming from Republicans. It was part of they didn't pass, but their attempts to repeal or replace Obamacare. And that was the idea of shrinking the federal government's role in Medicaid, so shrinking it financially, but also shrinking it in terms of the requirements that the federal government may impose on states. So it was, well, states, we may give you a little less money, but we're going to give you so much more flexibility in determining who's eligible for Medicaid in your state and what benefits you're going to cover and whether you'll have these work requirements. So is that, I mean, so now that's really kind of saying to states, go forth and experiment. So what do you all think?
So I can just give you my quick, again, it just came out yesterday, but the one thing that I found it was sort of, I think it's sort of a theme of this administration, and it's not it is a fact, it's not a criticism, it's they're not sure which way to go. And by that I mean, so here they're saying we want you to have all this flexibility, states, but we don't want to give you as much money. We're going to cap it. And two, all those mechanisms that you've used in the past to help supplant the funding that you should have been getting, the waivers, the different supplemental funding streams, we call it, we have a lot of acronyms, sorry. So the Uniform Hospital Rate Incentive Program, it's called Europe, the DISH program, et cetera. We're gonna look at those because we're not sure, states, that you're really doing those the way you should. So there's this dichotomy there that I see, or this lack of recognition that, okay, so you're going to give me all this flexibility, but that is going to cost us money, but you don't want me to do provider fees. You want to look at those. That's what it said in his budget was, I want to look at those. We're not really sure about how those really look. We were going to look at DISH because there were, the DISH funding was supposed to be cut in the ACA. It hasn't done. What's going on with that? These other supplemental funding mechanisms with regard to your waivers, while we understand that there's uncompensated care, is it really, how are you calculating that? So there seems to be this tension here, or there doesn't seem to be, there is this tension here of, we're going to give you flexibility, but only to a certain extent, because if you're going to be asking for additional funding through these mechanisms, we don't want that kind of flexibility for you. You're going to need to figure out something else. And for states like Texas, it's not going to be a tax. We're not going to raise taxes to do that. So I don't know where we would find this new magic pot of money for our Medicaid flexibility. It'd be difficult.
So I think we've got three things going on that tend to get conflated. One is the absolute number of dollars that is flowing into the healthcare system. And I'm sorry, when I first started teaching at U of H or whatever, it was, oh my goodness, it's 11% of GDP. And now it's about 19.8. We're up to 19.8% of GDP. That is not sustainable. Okay? It simply isn't. And as our population ages, there are going to be demographic pressures on that number. Something has to be done. So that's point one. Point two is the incredible complexity of the system and what that breeds. I would bet that, notwithstanding the fact that I'm sure there are many experts in this room, there is probably not a single person who really understands how any of this is funded. And what it does is it diverts resources into Byzantine optimization computations by people who are in the healthcare industry, who are thinking about, how to maximize this reimbursement, which may have absolutely nothing to do with patient care. And so an awful lot of brain drain is occurring in which our most talented people are working on things that in most societies, I am sorry to say, would be deemed idiotic. And unteachable, by the way, which is even more frustrating. Who here understands macro, really, okay? The third issue is this notion of freedom. And I would say it's kind of a that is, I don't think we can just give states money. I tend to be fairly conservative, but I don't favor that. I think that's problematic because I think you have run the risk of a state deciding, that, hey, we got money for healthcare, let's create the River Oaks jogging track, or let's create the Highland Park Dermatology Center instead of focusing on perhaps more redistributive needs. On the other hand, if you want a headache, what is the fastest way to get a headache? It is to read the Medicaid regulations. And it is unbelievably complicated, and I don't believe it actually helps healthcare. And so it strikes me that there is somewhat of a happier medium where we could get to things that are simple. Some of it may require a little bit of trust between the federal government and the states and reciprocally, but I feel like a move in the direction of giving states somewhat more freedom does make some sense. And we'll come back, I'll talk a little more about the issue with experimentation is it's not like a lab experiment where it's all controlled. There are an awful lot of variables that go into it, and actually trying to figure out what you've proven can be quite difficult.
So I think I probably sit a little bit to the left of you politically, but I agree with you on the point that providing some flexibility to states in certain areas would be a good thing for the Medicaid program. One of the things, and I am not a Medicaid wonk in the least, but one of the things that I became aware of fairly recently is just like how difficult it is to actually institute formularies within the Medicaid program at that state level. But if you could do something like that, you might be able to save a ton of money because you wouldn't have to pay for every single possible drug that's out there. You might be able to exclude some drugs that are more expensive than others. And maybe that would justify the reduction in the amount of overall funds that would flow from the federal government to states to fund Medicaid. I think that the question, from my perspective, just gets into a little bit of the details of all of those things, and I don't know that those details are hashed out, or are they even capable of being known to be hashed out, because probably that aspect of it's going to happen at the rulemaking process and not necessarily the legislative process, so you may not be able to see it up front in bill language if we actually transition to a system as opposed to just an open-ended entitlement for Medicaid to a system where you're going to get X amount of dollars for someone that's a child that's in the Medicaid program versus X amount of dollars for a person that's disabled versus X amount for someone that's in the workforce but below the federal poverty level, depending on how you do it. So those are some of the difficulties that I foresee in that, and kind of the devil's in the details, to quote that phrase. But I do see there's a possibility for some compromise there. It's just a matter, I think the thing that concerns me the most, especially when looking at what happened, I believe last year with the Better Care Reconciliation Act, is when you looked at the amount of money that would have disappeared from the current Medicaid program. It was a pretty hefty cut to maybe like 25% of the size of the program over a span of 10 years or so.
Especially if they went to like a per capita cap. So I'm not sure how familiar you all are with what happened with BICRA. It seems so long ago, but it was only less than a year ago.
It's a long year.
Yeah, it was. But for Texas, I mean, we are a very lean state. I mean, I know that you hear our elected officials say it's 30% of our budget is the healthcare budget. And to Professor Chandler's point, 19% of GDP, that's unsustainable. That same conversation is happening in the legislature right now. We just had a $1.2 billion shortfall that they have to cover in the Medicaid program from last biennium. But the issue there is that we are already such a lean state. We have a managed care. 93% of the enrollees in our Medicaid program are covered through managed care. So we have already a capitated rate. And so the BICRA program would have said, hey, by the way, you're at a per capita cap. So Texas would have been basically like double capped. We're already lean, so they would have started us low, and then we wouldn't have much to really go to, which would have put us, again, that whole idea of putting us upside down in that equation, not a great idea for Texas, because we are not a large earner state. A lot of the jobs that come here are low-wage earning jobs. There are, yes, big businesses that come here, and we're very excited to have them here, but they aren't going to give them middle-income salaries to start for many of the employees that they're going to hire. So then those families, if they aren't covered through their employer or not covered through their small business, and Texas has a lot of small businesses that don't often offer that, so they have to go through the marketplace, or they qualify for their children, or if you're pregnant and at a certain level of poverty, you go through the Medicaid program. So we're pretty lean with regard to how much we spend per enrollee. So I think that the whole idea of how do we compromise or how do we figure this out is going to, there is a lot of tension with regard to how do we make sure that what we're spending, is that juice really worth the squeeze, so to speak. And I think that's where the tension comes from lawmakers in particular, is that they're seeing a lot of money going into this program, and they're not seeing the data and the effectiveness and the efficiency of it.
Let me add on to this. I think definitely collaboration is going to be the key to the future success, not just to my opinion, the collaboration between federal and state governments, but actually a lot of service provision process happening between the collaboration between federal and local government units and the private sector. So instead of just thinking about it's the politics or political competition between national and state governments, indeed the process takes the three layers of the marble cake. If ultimately not just access to care, right, to individuals, but also the quality of care and the actual effectiveness of the service is what citizens demand ultimately. Definitely not just, again, the collaboration between federal and state government in regulating the process of delivering services as well, and cost containment as well. I think what we're missing here is really to think about some of the positive roles that can be contributed by the state, not state, the local governments as well, in terms of improving flexibility and effectiveness of service provision.
So sticking with the theme of flexibility, I want to shift away from Medicaid and move to the state exchanges under the Affordable Care Act. So the various Republican proposals out that they didn't pass, but the proposals that were out there over the past couple of years, in many ways would have given more flexibility to states when it comes to the state exchanges. So for example, there were proposals to give states grants that then states could use in a variety of different ways. They could use it to increase the premium or cost sharing subsidies to their citizens. They could use it to set up a more rigorous reinsurance program for high-risk individuals. Or they could set up a high-risk pool that might be somewhat separate from the state exchanges. But there were other ways that these proposals would have given greater flexibility to the states. So states could have had more flexibility in determining what has to be covered under an exchange plan. So states could have maybe significantly narrowed the so-called essential health benefits that plans would have to cover. So I know, Seth, you in particular have blogged a lot about this. So what are your views about giving states more flexibility when it comes to the state exchanges?
Well, I think we're seeing that even though the Republican health proposals failed, some of the Republican ideas are succeeding through the regulatory and sub-regulatory processes, and in particular through the granting of waivers. And I actually think that many of these things are a good idea, and that giving states additional flexibility, both on the making Obamacare more generous side, as well as tinkering with benefits, are a good idea. So for example, we see some states deciding to reinstate the individual mandate, but to do it on a state level. An advantage of that is there is no constitutional problem that I'm aware of, and it may help bring about lower premiums in those markets. And so having the flexibility to do that is good. Some states have decided, foolishly in my view, but still, let's give it a shot, to basically reinstitute a reinsurance program that will basically offload risk from insurance companies onto taxpayers. Now, the states are going to have to pay for this. That is, this is not going to be coming necessarily from federal money, although they've got all sorts of ideas about how it would actually save the federal government on the subsidy side, and so maybe they could trick the federal government into giving them enormous chunks of money back. Some states got away with that. There is flexibility on the risk adjustment program that is being put in by the Trump administration. In my view, that is a fabulous idea because I think a lot of the failings of the Affordable Care Act, particularly with respect to the co-ops, has to do with the technicalities of this obscure piece of the Affordable Care Act that very few people know about, called risk adjustment, under which insurance companies that insured high-risk people who were purportedly high risk would get money from insurance companies that would insure people who were purportedly low risk. And those payments could be quite large in many settings. And so one of the things that the Trump administration has done is to permit states, which is exactly what the statute says was supposed to happen, to actually have their own risk adjustment programs rather than rely on the Obama-era one-size-fits-all badly implemented risk adjustment program that they put forwards. And so I think giving the states some additional flexibility is a very good idea here. I don't think Obamacare has been such a wonderful success that, heaven forfend, we perturb any of its features. Again, there are bounds where I would have reservations, where I would say, hey, if you want to do that, you've got to get an act through Congress, which you haven't managed to do. But I think some liberality with respect to waivers, both on the conservative and liberal side, would be a good idea.
I wanted to add that the fact that the states that have so far joined the exchange programs, right, they actually take very different approaches to design and run these exchange programs. If you think about house exchange markets across different states, some states decided to have their state run only, right, state managed programs. Others actually heavily depend on federal grants and support, even technical support to actually designing and running the platforms. I would think this as ongoing excellent example of policy experiments or democracy in the laboratory in terms of having the flexibility and thinking about what works the best for their state-owned situations and the market, right? The fact that despite the bumpy rolling out of the exchange programs, and there has been recent studies showing that between 2014 and now, enrollment has been improving, coverage has been improved, and insurance rates have dropped substantially, and now we're at the historical low, below 10%, I think, a long time in history. That helped indeed to bring down some aspect of the healthcare cost, especially income-compensated care cost in some states, more successful states. Again, I do think that this is the positive aspect so far of the ongoing national healthcare reform, and indeed giving states and local more flexibility probably will be a way to go.
Here's one of the things that has always struck me as a little bit disingenuous about this whole conversation about essential health benefits. And my understanding, at least at the time that they were discussing, how do we decide what goes into these 10 categories of benefits, was that there was enough flexibility already built in where I think the insurance commissioners of each state could kind of decide what needs to go into a plan and what doesn't need to go into a plan. So theoretically, California could pick one thing and Texas could pick something else. There's been a ton of complaint on, we have all these different essential health benefits, and therefore that means, the prices of plans are going to go up because certain things weren't covered. And while that is true, a lot of the benefits that were asked for were already provided by most of the plans that were already in existence. The one areas where it really was not covered well were mental health, substance abuse, and maternity issues, and I think pediatrics as well. Other than that, things, and I'll call out my own group of emergency physicians, we complain that, oh yeah, if you get rid of essential health benefits, then no one's gonna have access to emergency care. That wasn't the pre-ACA status quo. Most plans had that, probably 90+% had that as a possibility. But it seems odd to me that people keep complaining, oh yeah, these essential health benefits are too restrictive, and they're making us put in so much stuff. Yet at the same time, realistically, the insurance commissioners of each state could decide within those 10 buckets, how many things had to be covered and didn't cover. And you can manipulate that already. But I didn't really see people trying to do that at that level. Instead, they just kind of wanted to complain and say, let's just get rid of all of this in the whole 10 categories, period. Which to me is it says, okay, I want people to have some kind of coverage for their pre-existing conditions as long as they're not women or mentally health, or people with mental health issues.
Right, so it sounds like a little bit what I'm hearing is when it comes to what benefits get covered, maybe what I hear you saying is a floor is a good idea, because maybe we're worried that some states will say, hey, cover what you want, and then suddenly there's no coverage for mental health care, no coverage for maternity benefits. But when it comes to the financing side, so how you might do risk adjustment, for example, or reinsurance, that maybe some experimentation would be a good idea. I think I'm hearing.
Yeah.
Okay, all right, good. Sorry, yes, go ahead.
This is for her in case she needs it. Hi, Deborah Mansfield, and I just came back from South by Southwest with a lot of discussion towards innovation relative to health policy, insurance coverage, et cetera. And one of the things that people are really kicking around up there is the new type of employee that is the gig employee, and not necessarily full-time. And how are we going to be restructuring benefits, not just the aged and individuals that are disabled or poor. So this is another thing that people are really kicking the tires on. So is there any opinion by any of you or any hearing, beating of the water in the wood somewhere that people are starting to bring this forward? Thank you.
Well, I'll start. I mean, it may be new to the people at South by Southwest, but in the health policy world, the bizarre putting together of the labor market with the health insurance market has been criticized by people across the spectrum. And it's persisted really as a result of historical accident and tax benefits. And I think if you were designing a system from scratch, why would you link someone's employment, which is a very lumpy, difficult market, to the essentialness of getting health care? But you could form pools that were not employment-based if that was the concern. And so, one of the good things about the Affordable Care Act was that it attempted to provide a non-employment-based alternative to employment-based health insurance. Now, that was corrupted because they had an employer mandate, which is still in there, which is designed to keep healthy people in employment-based plans rather than letting them go to individual plans where they could make those pools more sustainable. But if you were to ask me, if you were designing a system from scratch, I think very few people, very few countries would say, ooh, let's link employment and insurance together.
And this was thinking about the traveling nurse and shortages and how are we, putting benefits to keep individuals, still stickiness with an employer or being, content. So thank you for bringing that forward.
I have two questions. I mean, the discussion is, I think, a little strange when you guys say taxation in a state is likely to drive businesses away, because we see states like California, which have pretty high taxes and pretty generous benefits, having the largest population, largest number of millionaires, and states like Texas, and you guys are talking about having very low taxation, but at the same time also having a large number of not so wealthy residents. So that seems like dichotomy in the discussion to me. Second thing was, I think you brought up, for the first time you brought up discussion on local governments. I think that's very relevant since you live in Harris County. We actually have an excellent county's healthcare system. Yes, it's restricted by income, but I think the state is very conservative, but the county is very generous. So maybe if you guys could discuss these two issues, I would appreciate it.
So taxes first and then local government. Well, I mean, first, the obvious point, California, very blue state, Texas, very red state. California, they love to tax. They just do. I mean, and while I get what you're saying, it's like, yeah, but look, they have billionaires there. They have Silicon Valley. Yes, they have an incredible UC system. We also have an incredible UT system. I'm a little biased because I went there. And they were involved in that scandal in the New York Times this morning, so there you go. However, I would say that with regard to the way that I can't get into the mind of every leader that has led our state government, but it is one of those things where we're just not gonna, we don't want to have to spend money that is, if we're gonna use it to draw down federal match dollars, we don't want the federal government anywhere near us, except for it's as long, arm's length as we can possibly do it, and give us the flexibility, allow us to do our own thing. We're kind of that. We're going to have that independent streak. It's not to say that California has this dependent streak, but they love the partnership with the federal government. We have not ever loved the partnership with the, I mean, we do it because we need to.
I'm not talking about the philosophical differences. That's fine. I understand that part. My question really is, the logic breaks down. I mean, the basic logic, if you guys talk about, and you say that if we tax, residents will run away and businesses run away, really doesn't. We see evidence that doesn't work. New York taxes heavily. California taxes heavily.
And they're losing businesses to places
To
like
like
Texas and the rest. So I think
Yeah.
the theory works out actually pretty well.
Yeah, I would agree.
And the people who stay, by the way, they're businesses that manage to shelter their income offshore. So that's how they manage to live through the California high tax system. But
If you live, you don't live in San Francisco if you are a middle income wage earner in California. You live actually past Oakland now. You're out and taking a train 2 hours in to do a cooking job, a chef job, a teaching job.
That's for cost of living, not just taxes.
Correct, but it's a taxing state though, so it's not affordable. I mean, there's the affordability there, so businesses are coming here. They're incented to come here because it's cheaper to put up your stakes up here. It's just a faster way to do it too. Our regulations are easier too. I mean, California has other regulations as well with regard, just not just on businesses, but on the environment, et cetera, that are going to constrain. Whereas here in Texas, you can do that and strike your own.
I think your point is well taken. I mean, I simplified my presentation and presented it in a very black and white way, but I think it is more gray, right? I mean, because we do see some states that have, let's say, more generous welfare benefits for citizens in their states. It's not that everybody is at the bottom, right? And so, New York, for example, or Minnesota, right, have more generous benefits. Some of that, though, goes with spending in education and public services, right? States that are higher tax states probably don't have as many potholes, right, as we have here. The public education systems tend to rank higher than ours do, and that can be attractive to some employers. So I think, your point is well taken, and I think but I do think what's being said is true here too. I just think it's mixed. I think there are some businesses that for whatever, they are willing to stay in a higher tax state because maybe they value the public services, or maybe they feel that the talent pool they're looking for is in that state. But there are plenty of businesses that do look at the tax burden,
Look at
the
Apple.
regulatory
Apple's
burden.
putting $1 billion campus
Yeah.
in Austin, Texas. I mean,
Yeah.
that's
So I think
significant.
it's a more mixed picture. So I appreciate what you're saying, that it's not quite the way I described it, but I think it is true to some extent.
Your point is taken. I mean,
Yeah.
it is. I mean, look at what they're doing. But I don't think that our elected officials, though, are going to say, let me do a study on that and let me see where we're going to go with that. I think that they should point to my example. Look at Apple. Look at Amazon. Look at Rackspace. And those are all high tech, but I can also name 1,000 other smaller businesses that are come here and done quite well. Just around this. Look at TMCX, Johnson & Johnson. So, I mean, you've got a lot of people here that are saying, let's come and invest in here because the cost of living is cheaper. There are incentives here for us to stay here. It's more amenable to that.
I think political ideology of citizens do matter a lot in terms of deciding, aggregately speaking, what will be the willingness to pay for taxation in exchange of public service, right? If you think about the classic comparison, again, between California and Texas, that California has high income taxation, statewide income tax, and other types of taxations compared with what we have here in Texas. And if you look at public opinion data, right, like asking voters in California and Texas, especially in the context of healthcare, do you think, again, covering healthcare access to those who are with low income and sick belongs to the public responsibility? You see higher proportions of voters in California will say yes, right? It's a public domain question other than private individual responsibility, while you will see higher proportion of Texan voters will think, especially for the adult population, right? Being economically self-sustaining is deemed as a very fundamental value here. Not surprisingly, if you think about willingness to pay for taxation, right? I would bet my money that Californian citizens will say, yes, we're tolerating higher tax in exchange to more service provided from the public sector, while here, I think fundamentally it's the ideology-driven consideration as well, not just economic logics, yes.
Yeah, and I can attest to that, given that I grew up in California. I'm from California, and I moved to Texas for some of the reasons that were just discussed earlier. So I couldn't agree with you more in terms of the way of thinking. as far as who deserves and how much help goes to the public. Talking a little bit about cost of premiums, whether it be within the marketplace or outside the marketplace, in the end, consumers need lower premiums and their health needs to be taken care of. Some companies in the private sector are taking the lead, such as United Health Care. They just announced yet again that they're going to be passing some major discounts to the consumers. Some of these discounts are going to come from I guess they used to pay to the benefit providers or some sort of benefit companies that are the middle person between the companies. They're going to be passing that discount to the consumers. And that was announced yesterday. So it's been all over the news online. So they are taking the lead on trying to assist the consumers in terms of lowering their net expense in healthcare. Aren't they also contributing to some of this health policy? Don't they have any kind of power via laws?
The health plans have
to help?
significant power. I didn't want to skip over your local question because you asked about local too, but I think it kind of plays into what you were talking about too. So I mean, I want to give it to my peer. I mean, with regard to local, you're right. I think our Harris County healthcare system, it's very sophisticated. What I'm seeing at least in Austin and in DC is we're bypassing states now. We're going down to the local level for a lot of our innovation and flexibility, the social determinants of health discussions, et cetera. It's all being played at here, which makes sense. I mean, we know what our community needs, et cetera. It's not rocket science, and if it's safe environments, clean drinking water, et cetera. However, what I am also seeing here is that the state is saying, you know what, for these very Byzantine rules of how to get additional funding in the Medicaid program, we're going to do it at the local level. The state isn't going to put up the general revenue to pull down that federal match to pay a provider or health plan a better rate. We're going to let the local government decide how they're going to do it's called an IGT, an intergovernmental transfer. We'll let the local government raise the tax. We'll charge fees to all the providers, our hospitals here, to draw down that federal match. To bring that money here and spend it at the local level. They're called local participating provider funds, and it's something that all the hospitals here in this region are very much engaged to pass, because if not, we won't have the opportunity to fund our Medicaid program the way we need to for the citizenry here. And we're resource rich, but at the same time, we're shackled by the unwillingness for the state, again, to your point about taxes. The state is not going to pay for that. So they're saying, local governments, you decide how you want to do that. And we're okay with that. We're going to let you decide.
Yeah, this is one of the more complicated things. I can pretty much guarantee that if they allowed, Harris County to all of a sudden say, well, we'll pay for the Medicaid expansion ourselves, that they'd take it up because of the fact that what we see, I work in the Harris Health system, so I see this kind of thing day to day. I mean, we have a completely two-tiered system right here in the TMC. You have Taub, which takes care of, a very impoverished subset of the population, and then you have Methodist and Herman and St. Luke's that take care of the privileged. And this is one thing that I never really saw in practice where I was before this, which is one state that does try to represent itself as hard as Texas, that being Maryland, the wonderful state that does do all the price negotiations. So when you don't see people at Hopkins or some of the other institutions in Maryland kicking people out of the hospital because they are on Medicaid or uninsured, like I see happening here in Texas, and especially at some of these facilities, even within the Texas Medical Center.
I would beg to differ with that. I'm going to counterpoint. I've never seen that again at Texas Children. So, and Taub, to be clear, that is your mandate. Your mandate at Harris County is to take care of the indigent and uninsured and those that are undocumented. And so that is the purpose of that facility and that healthcare system is precisely for that. Versus you have private nonprofit institutions that are tripart missions of, especially on the Texas Medical Center grounds, of medical education, research, and care. So their missions are broader, and like Texas Children's, we are a partner with Taub. We take care of all the pediatric patients that come through, except for a few beds on the NICU side in Taub. So for us, it is our mandate, regardless of your status, citizenry not, insured not, we're not going to ask that when you come through my threshold of There might be other private nonprofits here that have that, but I've not, that would be, I think, the rarity, not the norm. I've not, in my 21 years here, I've not seen that.
Well, again, I did not specifically call out TCH because again,
No.
they're kind of a provider of last resort as well for the pediatric population. Whereas I think Taub and LBJ are kind of provider of last resort for the rest of the Harris County population. And again, it
surrounding
may
counties.
be relatively small percentages, but just looking at certain conditions that have been studied and published, there's millions of dollars that are, we find duplicated services or services that the county system has to take on as a result of people going from one hospital system in this area down to the public system. Whereas I never really noticed that as much when I was practicing in Maryland. And I don't know how much of it is because of the fact that there is sort of that equality across what each hospital is getting paid regardless of the insurance of the patient that's actually in that hospital. I don't know, it's just an observation.
From the data that I've seen, I think the largest proportions of Medicaid expenditures in this community happen at Memorial Hermann, at HCA, and Texas Children's, followed by the Harris Health System. When it comes to uncompensated care without health coverage, no Medicaid, the Harris Health System picks up the predominant portion of that. So if you look at the entirety of the safety net population in which receives services from hospitals in our community, if it's funded, we do have a series of hospitals that have taken that. If it's unfunded, our Harris Health System has picked up the primary portion of that program over the years.
And from Medicare, my United, whenever I was not under Medicare, I could go anywhere. I could go anywhere for anything. Now, they say we only take. I'm an educated, worked at high levels, MD Anderson, great places, and now all of a sudden, I have to choose my health insurance or my Part B based on my carrier because they do not take everything.
Yeah.
We don't have portability.
Nope.
In that sector. Anyway, and I am just so
So both
ticked
of your
off, as I could say
questions
here.
kind of lead into something else that I wanted to put forth for the panel, which is this reliance on the private sector and private health insurers. And it's kind of interesting that with both Medicare and Medicaid, they started out where the insurance company was the state in the case of Medicaid or the federal government in the case of Medicare. And then both programs have expanded so that are evolved in ways that now Medicare and Medicaid beneficiaries often are enrolled in a private plan that has a contract with Medicare and Medicaid. Right? So what do you all think about this? We've been talking about partnerships between the federal government and states or localities. Now we're talking about partnerships between the government and private insurers.
I mean, in Texas, that's what we do right now in the Medicaid program. I mean, it's all, Harris Health has their own health plan, so that would be the only public insurer, and Parkland as well. There's other public hospital systems that have insurance companies, but we have a health plan. United is part of the Medicaid program. The Aetnas, Cignas, the Superiors of the world. So you have that private enterprise that is part of a government program or participates through a contracted
I will
service.
add on to this, say part of this nature is also determined by the healthcare infrastructure system we have here. Despite the insurance provider system, if you think about who actually ultimately provides services to citizens, the U.S. is a very unique country where the fee-for-service system still exists, right? If you think about the entire universal population of the hospitals we have across the country, only about 1/4 of them, right, 25% of them are actually directly owned by public entities, primarily state and local governments. A majority of them, right, 3 out of 4, are still belonging to the private sector. So the infrastructure is not going to go away. in the near future and quickly. And this is still going to be the market structure that future rounds of policy changes are going to deal with. I personally don't have a huge worry about a private-driven or dominant provider system per se, because this is also a defining nature of the American system, where most exciting technology innovation happen here. The best doctors we have here, arguably, that a private-driven and dominant system can have the advantage of having the incentives, right, to encourage innovation, technology advancement, research investment, very heavy in that too. On the other hand, it creates issues and challenges, to my opinion, for price control, right? And not a coincidence that the American system also happens to be one of the most expensive medical systems in the world, partly because we don't have a very integrated market. We have more than 6,000 providers, if you think about hospital providers across the nation, very locally structured, issues of very tight local networks as well. That if you think about the locality, each local market niche, especially for specialized service areas, right, like very challenging treatment procedures, we have a lot of local monopolies. So price control turns out to be particularly challenged. So not a coincidence that we have the best technology, best personnel on the one hand, yet the most expensive system on the other hand.
Let me just follow up on that. It's a little bit of a digression, but I'll get back to the main focus. We always talk about America having the most expensive healthcare system in the world, which is true. But you should not, and I don't know how much of this has been covered elsewhere in this course, but American healthcare is not homogeneous. And if you look at the difference between the cost of healthcare in New York, cost of healthcare in Utah, Texas, there are huge variations in both practice patterns, what gets prescribed, and also in aggregate costs. And I sometimes think we don't actually have a cost problem in the United States so much as we have a state problem. That is, there are some states which just have not thought about cost control and are siphoning off an awful lot of money, and I think we ought to look carefully at that. If you haven't researched that area, have you talked about Dartmouth Atlas at all?
I don't know whether the other courses do.
Okay.
Not.
In any
It's a
event,
cool
the
data.
leading source would be to look at something called the Dartmouth Atlas, which studies these immense regional discrepancies and disparities in practice patterns. The second thing is, we have not been as vigorous, I think, as we should have been in enforcing our antitrust laws, in enforcing laws against monopolies. And if you look at the patterns that we see concentration of the healthcare industry leading to higher prices with somehow the alleged efficiencies never quite materializing. And I think we ought to be looking quite hard at concentration in the healthcare industry, and now we get back. Okay, so one of the issues that arises when we start talking about multiple insurers and competition is one of the disadvantages of that is they may be facing more than their match in some communities when they go up against a hospital that has basically a monopoly in some area, and they may not be able to do too much on negotiation of prices, whereas if there is a countervailing monopoly, the state on the other side, which can either through contract or through direct regulation keep those prices down, we can start to see a price of health care come down. So that if we're not going to enforce our antitrust laws and we are going to have a lack of competition in provision of health care services, then probably an unfortunate side effect of that is we need to think more seriously about more concentrated power in the hands of government, which usually I don't like. Now, the other solution that you hear bandied about for this is the public option that was originally discussed back in 2009, 2010 with respect to the Affordable Care Act, and it's making a comeback these days, which is saying if we only had public insurance companies that had the public interests at heart, our problems would recede. And I would suggest that that is the worst possible answer. Because first of all, our track record with how did that get implemented in the Affordable Care Act? That got implemented through not having the public option, but through having co-ops who would get these loans from the federal government. They ended up 20 out of 23 of them going bankrupt. The loans did not get paid back, and they were not particularly well run. Now, some of that is the government's own fault, but the track record of the public option in recent years has been pretty cruddy, and I would not be enthusiastic about seeing it repeated. But for the public option to work, it's attacking the wrong problem. It's basically saying, well, we could have a better insurance company, but if they're that much better, the private insurers are going to exit. They can't compete, especially if these public insurers are subsidized. And if the issue is a lack of competition in the insurance market, there are cures for that other than bringing in a public provider. We don't have public supermarkets. We don't have most things in the United States. We rely on the market to do that. And so while I have some sympathy for having the government run the whole darn thing and do battle with healthcare providers, this sort of middle ground of the public option strikes me as the worst of both worlds.
What about rate setting, right? Because you all touched on this. I mean, you were in Maryland, right?
Yeah.
A state that does rate setting in the hospital context. So what was your experience with that? What did you think?
I mean, my experience with it is more on sort of the equity kind of things that I noticed more than anything else. And again, I'm an ER doc, so I don't see like a lot of elective things. I see just people showing up that need to be there, or people that don't have other places to go. And the one thing that I noticed is, as you look from hospital to hospital to hospital, you just don't see a lot of. I mean, while there certainly is some degree of hospitals trying to pick and choose who their patients are going to be to a degree, I think there isn't as flagrant sort of pushing people out sooner than they may be able to otherwise. I think that what I've seen in other places is a much more bottom line focused approach to how you're delivering care.
Were there concerns in Maryland with rate setting that the government would set rates too low?
I think
and that all the hospitals would go bankrupt?
I think among the provider community, there's always that concern, and kind of one of the things that Seth was just kind of mentioning. You can certainly get prices down if you have one monopoly insurer and make it the government, because it's either you're going to play along or you're going to starve. So, that's one way to go about it. Personally, I don't think that's the way I would want to go about it, just because I think from the standpoint of providers, competition is a nice thing, because then you have the ability to generate some kind of income. And we've seen that, the hospitals and physicians do pretty well in terms of being able to have budgets that bring in money and are able to fund the operations that they want to fund. So I think that when you look at transitioning to a different type of financing or payment system, there's a lot to be feared from the provider community in that.
Additional questions?
Yes.
My question is, you talk about, especially when you talk about incentives as a doctor, we talk about fee for service and all these kind of things. I'm not an expert in medical service reimbursements, but I'm of the opinion that we should reward overall healthcare in terms of we should have less readmission rates. So the doctor's pay can be a base pay plus bonus based on how much was the overall effective care, fewer readmissions, fewer infections. Yeah, something like that. Yeah. But that is a little bit controversial in the US. So if you would just sort of digress from practical current laws, but on a more philosophical level, if you guys could share your opinions on how do you think is, at least in theory, how do you value that idea?
Let me start. I think since the enactment of the ACA, especially under the current healthcare kind of law regime, CMS has been experimenting on a couple of different ways of incentivizing, improvement of the care, the quality of the care, including value-based payments, and again, asking and requiring hospital providers to systematically report even the performance information, which did not happen before. Right, so again, first time in history that you have systematic documentation of readmission rates, mortality rates, and hospitals being rated. The bright side of doing this is that now we have much more data than ever before in terms of maybe in the next couple of years to actually commit systematic research to see if these kind of performance management practices actually paid off. My personal worry about this is that typically if you think about the management standpoint of view, that this potentially can incentivize provider organizations to go after those indicators that are easily to be quantifiable, right? Quality of care is a really complex concept and it can mean very different things for different patients, not just indicators of dimensions that can be measured numerically, right? And has an experience-based component as well. So I'm not sure how that component can be addressed by imposing such kind of incentive system, but it's going on now. I think back to 15, 16-ish hospitals nationwide are now ranked with the 5-star ratings, right? It's publicly available now. So an interesting aspect to me is also these kind of information also carries reputation cost and benefit for providers. Still too early to see systematic evidence to see again if these kind of practice will ultimately pay off or not. We've seen some anecdotal evidence that drives some hospital providers to think more strategically, for example, how they can manage those numbers.
One of the difficulties, I think, with that transition from fee-for-service to other value-based payment systems is, and this is an analogy I've heard out there, is that we essentially have a fee-for-service chassis and we're trying to add little bells and whistles onto it to make everything value-based. So we have a gas combustion engine, but now we're going to throw in a little hybrid up on the left wheel in the front. We're going to put a little nuclear over here, a little solar panel back there, and expect that everything's all of a sudden going to get better. And I think it's just, fee-for-service is not going away anytime soon. And so we're going to have to figure out a way to make those fees better in terms of representing what we want out of them. If there's a way to do quality, that we can measure quality outcomes that actually mean things, great. There are very few that actually have hit that mark. One of the big ones right now is the sepsis measures that every doctor is like banging their head against the computer screen about because we have to give antibiotics to someone that is diagnosed with sepsis 24 hours after the fact, but the antibiotics got to be given within 3 hours of checking into the hospital. So everybody's getting antibiotics. So then when we have, drug resistant everything,
Yep.
What do you want? That's what you're paying for.
Yeah.
So talk to your CMS.
So we only have a few minutes left, so I want to make sure we get all the questions in. Yes.
So our answer should be
I've had a lot of questions going in and out of my mind, but I did want to thank you for the readings because I've been a provider, and personally they really helped me step back and try to look at the issue from a 30,000-foot view. Philosophically, how do you think about policy instead of politics? Because I think so much of this is rooted in sort of one side fighting with the other. So the question I've been thinking about, and it was in one of the readings, they made a statement how in Canada, philosophically, the populace expects sort of healthcare as a right. And so they're much more in tune with taxation and paying for that, whereas here in the United States, we don't historically think of it that way. So as these arguments and discussions go on, do you think in some way our country is beginning to gravitate towards that sort of holding that kind of philosophy and willingness to do what it's going to take to get us there?
Well, I can
Professor
start with
Lin's
this.
research is in this room, so.
I think, I will caution about thinking about we don't recognize this as a right. I would say, if you look at voters' opinions in this area, it took this country about 100 years, right, to recognize entitlement just for certain populations, subpopulations, not for all individuals equally. So that's a fundamental difference. I don't see in the near future this deep-rooted philosophical ideas of individualism, especially for adult working population, that you're supposed to be economically responsible for yourself, right? Being responsible for taking care of your own social and health risks. I don't think this philosophical idea will easily go away, right? It's still going to be around. It's deeply rooted in how American people think about the role of government, not just in healthcare. On the other hand, if you think about the past century in terms of how public opinion has also been changed gradually, incremental in terms of, if you look at what we expect from the government now in terms of providing healthcare protection compared to what it was a century ago, we did indeed observe overall increased demand from the voters' population, right? So it will take time to evolve. My own observation about the ongoing impact of the healthcare reform is that now increasing number of individuals, especially low-income individuals who historically cannot afford access to healthcare, have been enrolled into coverage and gain access, and that fundamental change in policy experience is going to produce feedback effects, right? In other words, if you think about those who started to benefit from the policy change are likely to become stronger support in the future. But I don't think that rapid change is going to be in the near future. Yeah. Yes.
So I agree that we are seeing more talk about healthcare as a right. I think what's going to happen is people are going to focus on what that vague phrase actually means. Who has that right? Does a legal immigrant have that right? Does an illegal immigrant have that right? Does someone who's in the United States citizen but lives outside the United States have that right? Who actually bears the right? And then second, what is the content of that right? So supposing some drug manufacturer or some device manufacturer comes up with some new thingy-bob that increases the rate of survival by 2% and costs $4 million. Do you get that? Is that part of the right? And when we sculpt that right, what is going to be the source that informs the sculpting that right? Our Constitution has been interpreted basically to have no positive rights in it, except in the most very limited circumstances. You have a negative rights against the government bothering you, but no constitutional right from the government for anything. So since our Constitution for the foreseeable future is unlikely to be interpreted as having positive rights, where is that sense going to come from about how much health care does the government have an obligation to provide you? And to come back to the theme of this class, is that a right as a member, as a citizen of Texas? Is it a right of a citizen of the United States? Both? Neither? So, you know, it's all well and good to have, and I'm not criticizing you in the slightest, but it's all well and good to have, you know, healthcare is a right. I hear this all the time. But okay, tell me more.
So apparently we have about 30 seconds left, right?
If I could have 30 seconds.
Oh, sorry.
I just wanted
Yes,
to
30
share one
seconds.
thing from a professor I had named Larry Brown, and he kind of answered that question that you asked with the concept of social solidarity, and it's something that we see in Europe and in Canada that we just don't see in the United States. How quickly we're gravitating toward that, I'll go with her answer.
Yeah, I think there may be some generational changes when you look at sort of polls among younger generation, older. What I'm curious about is, as the younger generation gets older, will they continue to hold that view, the more conservatarian view or not? So, but I think we are out of time, so I want to thank my panelists. It's been a really interesting discussion.
Thank you.
And thank you all for coming.